false positive results represent a drawback for breast MRI, unfortunately. Regarding the MRI indications in our population, all our patients were performed in for diagnostic purposes. And to remind you that National Guard Saudi Arabia in Jeddah was the first center to start MRI-guided biopsy, and we started doing the procedures sometime in 2014. The data I'm presenting is around 2 years old and have been presented in the ECR 2019. At the end of this lecture, you will receive a link to get all the steps that we have covered in this lecture through that publication. So our patients were done for diagnostic purposes, pre-treatment evaluation of recently diagnosed breast cancer, and for evaluation of clinical or mammographic abnormality. So what we used to do, we used to look for focuses, small masses, non-masses enhancement, and we use it in cases of negative second look ultrasound or biopsy under second look ultrasound was discordant in pathology, or there was a targeting error during the second look ultrasound. So all these eligible patients for a second breast biopsy can either undergo second look breast ultrasound or subsequent MRI guided biopsy directly. What we used to do in our practice, that all patients with non-mass enhancement that are less than 1 centimeter, we usually bring them to MRI guided biopsy directly. Other patients were directed to second look ultrasound. So the patients were categorized based on MRI findings by the BI-RADS system. Eligible patients for a second breast biopsy who are BI-RADS 4 or 5 can either, as we said, go and for second look breast ultrasound or MRI guided biopsy directly. At that point, we did a total of 72 women with 77 lesions in our institution. Currently, we reached around 150 patients. The median age for the study population was 47 years, plus or minus 5 years. Among the 77 lesions, 65 were benign and 12 were malignant. This table is demonstrating the demographics in our population. So as we mentioned that the mean BMI for the patients was around 30. So most of our patients were obese to overweight. There was no difference in the laterality of the breast cancer. And most of our patients had a prior history of breast cancer or current history of breast cancer. Regarding the imaging interpretation, the images were interpreted by two breast radiologists. The lesion features were described according to the BI-RADS lexicon. So the imaging features that we evaluate focus, small masses, non-mass enhancement, negative second look ultrasound, biopsy under second look ultrasound with discordant pathology results, and targeting error during second look breast ultrasound. Okay, so these are the steps that we used to follow for each patient. So we do the screening or diagnostic MRI, and then after that, the MRI will detect the abnormality, which either mass, non-mass enhancement, focus, or distortion. We can evaluate the possibility of second look ultrasound. If second look ultrasound is not visible, negative, or discordant location or pathology results, then we do the MRI guided biopsy. So the MRI guided biopsy will be determined. Pre-booking, we check for contraindications like coagulopathy or in general, MRI contraindication. Upon arrival, the patient will have her cannula, will receive a contrast and appropriate positioning, and we have to discuss with the technologist the location of the lesion exactly, whether it's upper breast, breast or lower breast, and how far is it from the nipple, so the appropriate hardware is placed in correct location. For the procedure preparation, we do the aseptic draping, then we scan for lesion localization. Once the lesion localization is found, then we'll give local anesthesia, and then we'll scan again to check for lesion migration. During the procedure, we introduce the needle guide, and then we scan for the guide location. After that, we perform the biopsy, and then we will scan for the after the clip placement, we scan for the clip location for confirmation of the location of the clip. Post-procedure, adequate biopsy site compression has to be done. Post-biopsy mammogram has to be also performed to check for the clip location and for as a baseline. And then after that, we do the patient education in regard to the post-procedure care. We'll talk about it at the end of the lecture. So the contraindications are patients with anticoagulation or anti-aggregate treatment, patients with known allergy to IV contrast or local anesthesia, and patients with renal impairment. Post-biopsy results were concordant in 95% of cases, of which 14% needed follow-up, and discordant in around 5% of patients. So what are the pros and cons? So for MRI-guided biopsy, so it's a sensitive modality and it can detect occult cancers. Cons, it can lead to unnecessary biopsies as the negative predictive value is high, and management delay with median of around 20 days from other patients who have no MRI-guided biopsy. So how is the procedure done? So what are the equipments that we need? So we need the breast biopsy coil, we need the breast biopsy grid and plate, biopsy tray, which contain 22 needle for cutaneous anesthesia and 20 gauge needle for deep anesthesia. If needed, 20 gauge needle, spinal needle for lesions deeper than 3 centimeters, scalpel, gauze, and 10 cc of 1% xylocaine. So after that, we also need the MRI-guided biopsy introducer set, which contains the targeting block, the introducer, the depth placement cannula, and the obturator. And we need a high signal intensity marker like vitamin E or gadolinium based to be placed in one of the grid boxes for localization purposes. Vacuum assisted biopsy system is also needed, and vacuum needle, MRI compatible tissue marker, and post procedure set containing gauze, Steri-strips, and pressure dressing. So this is a sample of the things that we need during the procedure. And this is how the patient's breast is being placed, and it needs just gentle compression. So the pre-procedure steps: prior to presence of prior imaging, The patient has to consent, and the radiologist is usually the one who is responsible for consenting the patient, because he is the one or she is the one performing the procedure and knows the ins and out of the procedures. The procedure is explained to the patient with its risks and benefits by the radiologist performing the procedure. MRI contraindications are reviewed by the MRI technologist, and brief history is obtained by the breast technologist that aid in the risk stratification and help in the study reporting. We have to be sure that the patient is not on anticoagulation or anti-aggregates. You have to ask the patient specifically for this. I know that I've mentioned this before, and I'm mentioning it again because it's really, really important. So this is the questionnaire that we use in our center that is obtained by the breast technologist. And this is the questionnaire that is obtained by the MRI technologist for the MRI screening. Pre-procedure steps. First, we have to determine the position. So the study is performed in the prone position with the breast of the interest is positioned within the breast biopsy coil. The lesion from the nipple, proximal, mid, and distal, and above, below, or at the level of the nipple is determined. And the technologist performing the procedure has to know the location exactly, as she has to place the grid in the correct location. And in relation to the skin, whether we should go through medial approach or lateral approach, or if the lesion is in retroareolar location. So this is how the patient is positioned. Approach. So the approach is determined by the lesion location. Lateral approach is always preferred due to better lighting and easier needle manipulation. If you choose the medial approach, it's not wrong, but you have to know that you are going to go beneath the patient, and the lighting might not be that good, unfortunately. This is the sheet that we have to fill for each patient who is undergoing MRI guided biopsy. So this is the image view. So this is how you see it and visualize it in your monitor. And this is the patient view. So you have to determine the box that the abnormality is there. Remember when I told you you need a vitamin E marker or a high signal intensity cube? You have to place it in one of those rectangles so you can know exactly where is your location. So it will help you just in the location of the lesion itself. So you have to determine which box. So after you determine, let's take, for example, box number 8. So you have to mark it here and there. And then you have to know within that box which way you want to go. So you have to choose which opening you want to choose according to the lesion location. And then after that, you have to mark the depth and the depth of the block and the depth of the introducer. So the depth of the block is unchangeable usually, and you have to add it to the depth of your target and calculate it. So when you do the procedure, you can adjust for the measurements. So if you follow these simple 12 steps, you will be able to perform the procedure easily. So we have to use the targeting block, which is placed in the grid guided by the grid worksheet. So it's the one containing the high signal intensity that I told you about. The opening within the targeting block is determined. So as we saw in the previous sheet, which opening we want to go through. And then after that, we do skin incision at the area of the opening within the targeting block. We have to place the depth placement cannula from the set as per measurements in the worksheet, adding the +2 as you remember. Then the introducer is introduced into the depth placement cannula and is inserted in the patient's breast to reach the target. The introducer is replaced by the obturator, and then scanning can be performed for localization of the obturator. If the location is satisfactory, obturator tip is at the proximal edge of the abnormality. So if the abnormality is here, the obturator has to be here. So it shouldn't be inside it. The obturator has to be here. So when you place your needle, the needle will go into the lesion itself. Then after that, we do scanning while the obturator again is placed to ensure adequate sampling of the abnormality. If the sampling is satisfactory, a tissue marker is placed, and after removing the depth placement cannula, another scanning is done to confirm the tissue marker location. After that, post-procedure mammogram is performed as a baseline for tissue marker location. Keep in mind, if you encounter hematoma during the MRI-guided biopsy, more vacuum can be applied during the procedure itself. So how do we assess the sample adequacy? We assess the sample adequacy by scanning after the procedure. So you should see the area of interest is no longer seen because it's in your container. And you have to choose which media you want to send the sample in. So for example, if you are looking for malignancy in general, formalin, if for example you are interested in lymphoma, you might need to send it in saline. If you need to send it for tissue cultures, for example, in cases of granulomatous mastitis or other mastitis cases, then you have to send it in the appropriate containers. What are the technical limitations? The challenging facing the radiologist are either patient-related or procedure-related. The patient-related include uncooperative patients, limitations related to the breast size and the presence of breast implants, and procedure-related, which can be due to lesion location, multiple lesions, lesion visibility, development of hematoma, and tissue marker-related issues. Post-procedure care, so we bring the table down, we roll the patient to the supine position, and then we apply compression, manual rather than sandbag, because manual compression is stronger. And then we apply wound closure strips and dressing, and then we obtain a post-procedure mammogram. So the post-procedure care, first is manual compression, manual compression, manual compression. And then we apply the stair strips over the skin. Usually the manual compression should be performed for like 5 minutes. And if everything is fine, then you can stop. If not, you can continue as needed. Usually does not exceed 15 minutes. The pressure dressing afterward is applied, and the patient is advised to keep the area dry for around 24 hours post-procedure. The patient is also advised to wear a supporting bra. So the aim of the supporting bra is that the bra will hold the breast while the patient is moving. So she won't have any discomfort during moving or sleeping even. The patient is advised also to refrain from upper body physical activity and to take paracetamol if needed. The patient is giving information on how and when where to receive the biopsy results. In our institution, the patient comes to the clinic to get the biopsy results after 1 week or 10 days after the procedure. And the patient is educated about the red flags. After that, we think that our procedure is done, but it's not. So we have to issue a concordance report once the pathology result is out, and the concordance report is we mention the study and the report concordance and give appropriate recommendations and assign a final BI-RADS. This slide is very, very important for the concordance report. So we have 5 categories for concordance: concordant malignant, concordant benign, discordant malignant, discordant benign, and high-risk lesions. So we say that we have a concordant malignant when we think on imaging that it's suspicious, and the pathology confirms that it's suspicious. So it's malignant now. So what's the course of action that has to be performed? The course of action, the radiologist should communicate the biopsy results with the referring physician, and the patient should be informed of the results, and the referring physician has to do appropriate treatment. So what if you think that your imaging findings, you think that the abnormality is benign, but it turns out to be malignant of pathology. So this is discordant malignant. So the radiologist has to notify the discordant results to the pathologist and discuss it with the pathologist and
ياخذ جرعه واحده
notify the referring physician.
ما فهمت عليك.
And then communicate the biopsy result to the referring physician, and the patient should be informed about the result, and the referring physician has to initiate appropriate treatment. And it's called concordant benign when the imaging findings are favoring benign and the pathology is confirming benign. There is no standard follow-up guidelines. We follow annually if the lesion needs follow-up, otherwise we don't do any further follow-up. The lesion is called discordant benign when we have suspicious imaging findings and the pathology is benign. So we have to discuss, in this case, the study with the pathologist. We might need to repeat the biopsy and we might need to get larger samples. So we cannot let go with this. So this is the only case we have to go back. High risk is when with any imaging finding and the pathology show high risk lesion, but you cannot call it high risk concordant until you have a large sample. Because if you get a small sample, small cores of 14 gauge, your upgrade rate can reach up to 40%. So you have to be sure that you remove the whole lesion and you have used a large biopsy system. The management is controversial and depending on the biopsy results, and case-by-case approach between the different specialties is needed in such cases. So in conclusion, MRI-guided biopsy is a safe, simple, and fast procedure that can be performed with minimal training. The biopsy can spare the patient surgical biopsy and may reduce the resurgery rate. These are my references and acknowledgement of my research and technical team. Thank you very much. By this, we conclude the first part of the lecture. Let's take 15 minutes and come back for the case-based discussion.
Yes, fine. And الحمد لله على السلامة. سلامتك دكتورة.
الله يسلمك. شكرا.
تقدر توقف الكاميرا دكتورة إذا تبي ترتاح.